Hello friends, welcome back to my channel with a new video. And this time we will be discussing an interesting clinical entity pertaining to obstetric critical care, which is quite close to my heart. And actually this I delivered during the obstetric critical care workshop, which got recently organized by the annual national conference of critical care medicine ISCCM in the city of Chennai. So, as usual, we will divide it into two parts. So, without wasting the time, I'll start. Now, let us start with a case. So, this is a 32 years old female, G3, P2, and in the second para, she had history of preeclampsia. This time it is P3 and it was a normal vaginal delivery. Following that, day 0 was essentially uneventful with mild fatigue. But on day 5, she had progressive dyspnea and where the family noticed it. On day 7, she actually had quite a severe dyspnea. She was taken to an ER and then we saw this patient. The vitals were BP was on like a borderline, with tachycardia, saturation of 88% on room air, bilateral crepitations, raised JVP, cold extremities. ECG was sinus tachycardia with no specific STT changes, so it was essentially non-specific. So, what actions did we take? So we went ahead and did the ABC, the airway, breathing, circulation. She was tachypneic, hypoxic, so she was naturally put on NIV with a CPAP of about 12 centimeters and some furosemide which was given to relieve the symptoms of pulmonary edema. And of course, she had hypotension, so the first drug of choice, which should be very clear, is noradrenaline. And mind you, there is some kind of myocardial depression or myocardial stress which we encounter with dobutamine. So the message is very clear. We need to actually go ahead and start some noradrenaline to these patients. Immediately, the POCUS was performed, a bedside echo which showed severely depressed LV ejection fraction of about 26%. She had a severe mitral regurgitation with global hypokinesia. There was no evidence of regional wall motion abnormality whatsoever. The left atrial size was about 48 millimeters, and as we know that anything beyond 40 is abnormal, so it was a dilated LA. At the same time, if you see LV EDD of about 62, which falls in the moderate category of LV dysfunction, so anywhere above say 50, 52 or 55, which we say that it is LV dysfunction in terms of LV EDD. There's no pericardial effusion and no RV strain at this point in time. So this brings into the vital point of how we define PPCM or what are the different criteria. So it has to be acute or subacute, and it causes severe cardiac degeneration. Usually it is encountered in the last month of pregnancy or the initial 5 months of the early postpartum period. So classically it is a maternal heart failure with systolic dysfunction as is seen in our case without evidence of ischemia. So anything where the LVEF which is less than 45% without any concurrent heart disease or a prior history of heart disease, and the onset of this particular entity in the last month of pregnancy or maybe the initial 5 months of peripartum or the postpartum period. There are few cases although which can be encountered even after 5 months, and 15% of such patients can actually present as cardiogenic shock. So uh, there are many references, and the majority of my reading or the literature is based on European Society of Cardiology guidelines 2025. So this is how you define as far as the labs are concerned, as you could see, the BNP was high, troponin I and CPKMB were also high, LFTs were deranged with creatinine of 1.8, and the TSH normal with seronegative, that is retrovirus negative. So it's very clearly that she had definite cardiac dysfunction in terms of lab parameters also. And as we know that the BNP is an active biomarker, whereas anti-pro BNP is inactive biomarker, and the cutoff of anti-pro BNP is about 300, whereas the cutoff of BNP is about 100. And of course, if the patient is on ARNI, we will actually we will rely more on anti-BNP. And if there is a renal failure, then probably BNP is little more sensitive or specific than anti-pro than other cardiac biomarkers. So this is just a addition to the cardiac biomarkers which we see. So it is said that when the BNP is more than 1000, it carries about 95% sensitivity for PPCM. And often it is a diagnosis of exclusion where you encounter sinus tachycardia with echo suggestive of systolic dysfunction in absence of structural abnormalities, no RWMA, or there is presence of global hypokinesia, which was seen in our case as well. There's a LV dilatation. We may go ahead and do a cardiac MR in few subset of patients. BNP we talked about, and of course there are few AI-driven ECG readings and a novel biomarker in the form of miRNA. And then we may actually also get indulged into genetic testing, which is relevant or more important in the patients who want subsequent pregnancy, or when we are counseling this kind of patients based on their clinical findings and in the for the futuristics. So, as we know that we talked about PPCM being the diagnosis of exclusion, so we need to actually know what are the differential diagnosis or the various differential diagnosis for this particular clinical entity, starting from the pre-existing cardiomyopathy or pre-eclampsia induced pulmonary edema, pulmonary embolism, valvular heart diseases which may have missed in the antenatal period, and of course chemotherapy induced cardiomyopathy for someone who is on doxorubicin or other agents which can depress the LV. Other causes like MINOCA, which stands for myocardial infarction in the non-obstructive coronary arteries, myocarditis, I will definitely consider Takotsubo cardiomyopathy, and of course sepsis, which is definitely there. So in about 30 to 40% of the ICU patients, you may actually have overt sepsis or occult sepsis. So as far as the classical signs and symptoms are concerned, we would definitely know that this patient presents with dyspnea or orthopnea with raised JVP, crepitations, pulmonary edema, cardiogenic shock, arrhythmias, and of course thromboembolic events, which is seen in about 5 to 20% of the patients. As we know, pregnancy is hypercoagulable state, so you have to be cautious about this particular uh, factor. So, what were the risk factors as far as the developing PPCM in any patient is considered? And we will look at our patient also. So, she had history of preeclampsia, which is an important risk factor. Multiple gestations also. She falls into this category with advanced maternal age. Again, she was more than 30 years, 32 years. So, of course, she has this risk factor as well. Anemia, and Indian ancestry also is one of the important risk factor, and mind you, in 20 to 50% of the patients the relapse risk is in future. So once the patient has PPCM, you need to be very clear in your mind when you counsel this patient that in future pregnancy they may have chance as high as 50% that this patient might develop PPCM, although there is a complete or a near complete recovery from the previous event. Now, these are few of the neurohumoral mechanisms which are known. As we know, the pituitary actually secretes prolactin, and it has a negative effect on the cardiac myocyte as well as the cardiac vasculature, and the various hormones which are secreted also by the placenta like progesterone or activin A and the relaxin, which will have an impact on the cardiac vasculature as well. So let us see the case again and come back to the case where we treated her with furosemide, hydralazine, beta blockers, and as we will discuss, the beta blockers are the ones who are reasonably safe in pregnancy and which actually have mortality benefit. In this patient, we did not give ACE inhibitor, neither ARBs were initiated as of now, and the patient was fairly responding. So we were on NIV, we were on small dose of noradrenaline along with these drugs. So I think I'll stop at this point of time. Let us come back with the part 2 of this particular topic in my next video. So that's all for now. Thank you.